Hello everyone. In this video, we're going to talk primarily about Chapter 6 of the textbook, which covers diversity in healthcare and health communication. There are a lot of pros, cons, challenges, and a lot of things in between when it comes to the topic of diversity. In fact, even the very word diversity, how many times can I cram it into this video, I wonder, is subject to a lot of different definitions. So let's start to get into what it is, how it functions in health communication and healthcare, and why it might matter for us. Now, we have already talked about this subject, why representation matters in healthcare. And one of the clearest lessons we get out of that body of research is that it seems to be often a cross-cultural issue, perhaps more so than any sort of malicious racist intent when it comes to some of the health disparities that we witness. However, it's never a super clear picture as to why we can, in fact, notice a lot of different health outcomes, health risks across different groups. There are many different reasons for that, and the research has tried to identify a lot of those. When it comes to diversity, we have to be very careful to walk a delicate line between noticing trends associated with certain groups and attributing reasons or causes to those trends. It's rarely as simple as we might like to think, but by discussing these kinds of trends and digging into them and investigating them, we can start to get more useful health information. But I think that the lesson with most of the diversity stuff is going to end up being what can we do to better improve our own perspective taking ability, our empathy, and our knowledge uh, in order to try to treat people like people, right? If you want to be a healthcare provider, it's again, the ultimate inequity is treating each individual individually. So how do we try to do that rather than fall back on categorical differences that might be observed at different levels of analysis? Now that actually brings us to one of the most perhaps famous theories having to do with diversity, which is intersectionality theory. Maybe you've heard of this before, um, but I think that healthcare is a particularly important context to consider the implications of something like intersectionality. Now, depending on what you've heard in the cultural conversations, what kind of conversations you're engaging in. This is talked about politically a lot of the time. It's often discussed on Reddit and Facebook and all the dark corners of the internet where people argue about these things, Twitter. But it's going to be really important for us to have a clear understanding of this. So what does intersectionality theory teach us? Well, what it does is it stresses the importance of a multi-dimensional picture of diversity that was relatively unique when intersectionality entered the scene in terms of not just focusing on one categorical difference, but recognizing that people have complex identities that exist as the intersection of a whole lot of different factors. And it makes us somewhat irreducible. So we're recognizing that each individual is the intersection of multiple identities, and that in itself is recognizing the dynamic and individual nature of identity. We have to acknowledge that social problems cannot be broken into separate issues that only affect specific identity groups. Now, what we do with this information in this specific context, well, as patients and providers and even politicians, right, may benefit from both recognizing the big picture trends, and that means being able to identify actual health disparities that are associated with some of these different identity groups, but at the same time, recognizing the importance of individual lived experience. And so intersectionality theory is kind of trying to combat that fallacy I've previously described, the ecological fallacy, where we can observe perhaps a trend at a certain level of analysis and we apply it to the individual incorrectly. Another fancy word for that you may be more familiar with would be a stereotype. Stereotypes can go both ways, right? Maybe you see someone from a given group doing something and you're like, oh, wow, everyone from that group must do that thing. That would be a kind of stereotype. But so would be detecting a trend at associated with a certain racial group, for instance, and then attributing that to members of that race that you meet, right? kind of goes both ways. And so intersectionality is an important reminder for us that people are in fact unique and they have a lot of different unique identities so that we can avoid making those kinds of fallacious assumptions about them. But as I mentioned before, there's always going to be a dialectical tension between noticing real trends out in the real world that are associated with these different demographic groups and trying to see if we can reduce those kinds of health disparities and improve people's health outcomes, but also recognizing that the best care is going to be individual care, dealing with individuals with their individual risks, individual lives, individual experiences, and there's going to be no replacement for that. If you have heard of intersectionality theory before, it may have been in a more controversial context, but in reality, this theory does not need to be nearly as controversial as it's often made out to be. For example, criticisms of intersectionality theory argue that it seems to be saying that based on your different categorical differences and the intersection therein, you can be way more or way less privileged. And it seems to be used sometimes as the social currency, saying, well, I'm part of this group, and this group, whereas you're part of that group, and that group. Well, that's not what it's supposed to be about, but it is often discussed as if it is, and the theory can be misappropriated in that way and used as kind of a cultural weapon. That's not the goal of intersectionality theory. Intersectionality theory is, again, it's worth reiterating, it's trying to get us to recognize the uniqueness of individuals and the consequences of making assumptions about people. So, what is diversity and how do we do it, so to speak? Let's take a step back and consider that. For one thing, we can identify demographics. What's a demographic? Well, a demographic is a group characteristic. I'm sure you're familiar with many of them. We're going to discuss some of them here. Typical examples would be age, race, religion, ethnicity, sex and gender, all of these different categories. Sometimes we use these categories to describe what have been referred to as master identities. A master identity just means it's an identity group that you were born into, and you may not have a whole lot of influence over how that changes. So sometimes something like religion falls into this category, because whether or not you choose to practice a religion, most people are born into a specific religious and cultural context, and that shapes how they are socialized, how they grow up, how they view things like health and well-being, and all that factors into that. So that might be, even though you might think of religion as something you do by choice, it's also kind of falls into the category of a master identity. Other things we can't change, such as our age, have profound influences on our risk factors, but also how we conceptualize and enact health and are treated by society. So we want to deal with some of these things and figure out what to do with it. We, as health communication people, can use these pieces of information to enrich our understanding of human lived experience, but we need to be careful about applying them to individuals that we meet and making assumptions about them. So again, let's maybe try and use the lessons that we learn here to enrich our understanding, but still try to reserve judgment and minimize assumptions that we have to make. Because as we've talked about in the past, making those kinds of assumptions can be very detrimental and add a whole lot of uncertainty to exchanges and increase the likelihood of having consequences we just don't want. I want to begin digging into some of these diversity factors with health literacy. I was pleased that the textbook put this pretty early in the chapter. I would put it even earlier than as they did the socioeconomic stuff, which is what I'm doing here. Now, socioeconomic, between the two of these things, and they are often interrelated, as we'll see, but health literacy and socioeconomic status are some of the major predictors of health outcomes. Like, these have profound influence on our ability to access healthcare, use healthcare, and achieve better outcomes. So I want to start by talking about health literacy, because I don't want to give you the impression that being a member of a certain group has sealed your fate or anything like that, right? That's not how these demographics work. And that's, again, trying to recognize one of the important lessons of intersectionality theory, right? We could have very high health literacy, but be associated with a group that has some very poor health outcomes. And one is going to be more predictive than the other. this is it. So health literacy is the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions that may affect the health of Americans and the ability of the healthcare system to provide effective, high-quality care. So what we are dealing with here is how well do you understand health information? And this varies significantly across the United States. 88% of US adults are considered to be below the proficient level of health literacy. What does that mean? Proficient, according to the National Academy of Sciences, is saying that you might be able to find the information required to define a medical term by searching through a document. Intermediate level, which would be below proficient, might be able to determine a healthy weight range for a person of a specified weight on a BMI chart. If you've never seen a BMI chart, I'll throw one up on the screen for you here. Basic might be able to state 2 reasons a person with no symptoms of a disease should be tested for the disease based on information in a clearly written pamphlet. And below basic means you might be able to locate and circle the date of a medical appointment on a hospital appointment slip. That's a problem if you cannot do that. And imagine how being at any one of these levels could interfere with your health outcomes and your health care. Health literacy is incredibly important, and it's not nearly high enough. It is getting better all the time with the access to information and technology and more resources, but health literacy is also tied to some other factors. And by tied, I mean, well, associated, correlated with some other factors such as socioeconomic status, that it becomes kind of a big red flag for health outcomes. And we want to, whatever else we do, strive to improve health literacy across demographic groups. That's going to be very important for establishing health equity and health equality of access and things along those lines. So again, for example, here you have a body mass index chart. You can see here the different categories. On the left, you have your weight. On the bottom, you have your height, and then you have this table illustrating what a healthy weight would be for someone with your weight and height. Are body mass index charts the end-all be-all of health? No. But if you can't read one, then you might be below the intermediate level of health literacy, which is going to be not ideal. Now, one of the biggest considerations for health literacy is knowing how to talk to what audience. This is essential for health communication and audience analysis, because if we want to be having effective communication, we really have to consider the people we're talking to and their ability to interpret the message we're giving them. So an example of this would be, how could you explain vaccinations to a 5-year-old? Right? Can you describe a step-by-step process that would be appropriate to that level of education to the best of your knowledge? The Explain Like I'm 5 thing, there's a whole subreddit devoted to this, but it's kind of a little thought experiment of like, well, all right, can you simplify this technical subject? Well, how do we do that? It's a great example of health communication. But it also depends on our level of knowledge. How well do you understand how vaccinations work? Maybe it depends on the vaccine. mRNA vaccines are a very different mechanism of action, than an attenuated virus or a dead virus or something along those lines. But that's kind of neither here nor there. How would we explain this process to a 5-year-old? And what kind of qualities about a 5-year-old are you imagining? As we'll see later on in this video, age is a very important factor when it comes to diversity, and how we talk to children and how they understand healthcare, health knowledge is also going to be very important for helping them achieve good health outcomes. So here are some of the other diversity factors that the textbook is bringing up for us, and we're going to go through these one by one to increase our understanding of this. You have race and ethnicity, socioeconomic status, language differences, age, disability, and gender identity and sexual orientation. These are not all of the possible diversity factors that have influence over our health outcomes, but these have some noticeable trends that can get our brains going in the right direction here. Let's start with race and ethnicity. This is what most people think of when they think of diversity. It's not surprising. We have spent a lot of time as a culture being fixated on race and ethnicity. Now, race is a pretty loosely defined term involving hereditary background and social identity, both mixed into the same kind of thing. So there's a great deal of cultural context influencing this as well. What do we consider to be a distinct race and why? Ethnicity has to do with our cultural identity. The go-to example in the United States would be Hispanic. This is an ethnicity. You could be white, you could be black, but you could still have more in common with each other if you come from a Spanish-speaking country than whites and blacks in the United States, right? Ethnicity. Race, ethnicity, and health are interrelated, though not always clearly. Now, there are different risks and outcomes that exist for different groups, and we can measure them in terms of seeing these measurable outcomes. We would refer to those as health disparities. Now, when we can detect these kinds of differences associated with something like race and ethnicity, people might be tempted to make racial generalizations and assume that this is something like hereditary or like there is a profound difference. Now, sometimes there are biological differences between the different racial categories that we are familiar with, but not always. And it's not always a very clear picture as to why those differences exist. They could, in many cases, be equally likely due to socialized factors or something hereditary. And it's not always clear why. The question of why can be important if we're trying to treat these conditions, but perhaps it's more important for us to recognize that these are differences that we can see in the real world and we might anticipate encountering them. The textbook identified three major reasons why we might be able to detect these disparities. And these are good things for us to focus on because they're things that we might have control over or be able to influence as a society. We don't necessarily have control over a genetic predisposition if that's something that we can, even if that's something we can detect and identify. All we can really do with that information is help understand stratified risk based on different demographics. However, these three factors that the textbook gave us to consider, well, this can be useful because we can perhaps influence these things. So one of them would be distrust. We've talked about this factor in the past when mentioning the health belief model. For example, the Tuskegee syphilis trials, a notorious instance in which the U.S. Public Health Service studied the progression of the syphilis disease ongoing over decades, really, rather than treating people for that disease as that particular notorious study claimed it was going to do. It doesn't help that they performed this study in a poor black community. So this was influencing, the consequences of this were disproportionately affecting a specific population. Now, if that happens to your group, your racial group or your identity group, you might have some trust issues with the U.S. government, right? Distrust is a major influence as to whether or not people are going to seek health care or listen to the health messaging of that authority or agency. There's also minority groups tend to have higher risk factors and lower health literacy. Again, this is a trend, and whether an individual has that health literacy is going to be more predictive of their health outcomes than their minority group. However, we do notice this trend. It could also be cultural, it could be linguistic, which we'll get to in a moment. There's also a limited access associated with these different groups. Again, a detectable trend that might be more associated with something like socioeconomic status. All of these things are associated. And so it would be a mistake for us to assume that it has to do specifically with the race or ethnicity, so much as there is an association between that and more predictive factors such as health literacy and socioeconomic background. So again, it bears repeating here that best practice for a practitioner, if you ever become a provider, is to treat people based on their individual characteristics, not their group characteristics, but to have a basic understanding of some trends that we can detect. So again, socioeconomic status, this is one of the most influential factors in health outcomes. I would say this and health literacy are right up there on top. And This is often happening through a lack of access to resources or healthcare. People in urban areas can be in what's called a food desert, where they don't have access to fresh food. They're just maybe gas stations around or something like that, lots of processed foods, which are not healthy things for us to eat. Crime in these areas, in low socioeconomic status areas, drugs, pollution, lower education levels, all of these things are associated with socioeconomic status. Additionally, there are stereotypes and barriers of perception on the end of healthcare providers and authorities in terms of stereotyping people who come from impoverished backgrounds as having any one of these other factors associated with them and their identity, right? Assuming that someone who is poor is also going to be a drug addict or low education or something like that, right? We want to avoid those kinds of stereotypes while recognizing that these factors are incredibly influential to our health. It is likely more explanatory than other demographic trends, which compounds the difficulty, it compounds difficult health decisions, such as if you need to decide between getting a food this week or a certain medical procedure, but it can also complicate seemingly straightforward decisions, whether it's, I don't think I can afford to get antibiotics, even though I need them, right? Something that would seem to a provider to be a no-brainer. You need the antibiotics, get them. But to someone who's coming from a socioeconomic background and is living paycheck to paycheck or doesn't have a pharmacy in their area. There's any number of these factors associated with socioeconomic status that can dictate health decisions. Now, language differences. Again, I mentioned before, if we're looking at something that is associated with a racial or ethnic minority, well, it's more likely that that language barriers are getting in the way of this. Also cultural barriers, we'll get to that in later chapters here, but language differences are huge. And if we recognize that health communication matters, well, we definitely need to recognize that not speaking the same language is going to increase communication barriers, and that's going to get in the way of effective communication and good health outcomes. Not very surprising here. But this is a major challenge for travelers and immigrants. Some people could uncharitably assume that this only affects like illegal immigrants or something like that. That's not the case. As we can see when it comes to representation in healthcare, you can still speak the same language and have problems. So if you are speaking through your second language, third language, or a language you do not understand, that's going to be a huge issue. There are usually provisions for interpreters to be available to patients, and there are different programs and government programs. It's not always clear to patients who's going to pay for that. It's not always clear to hospital systems who's going to pay for that, and it's not always accessible and available in all forms. It might need to be phoned in. So often people are using their loved ones as interpreters, and that adds a couple layers of difficulty. Regardless, interpreters are not they're not robots, right? They're people too, and every person you add adds complexity to the message exchange. So we can see very quickly how this can compound things. And if you happen to go to another country, you'll start caring about that very quickly. I had a variety of exchanges with a variety of healthcare professionals when I lived in Japan. I lived in a fairly rural area. Most of these doctors I was seeing had never seen a white person before. They definitely didn't know how much Japanese I spoke, what my health literacy was. Some experiences were good, some were bad. It's just the way it is. This is a natural consequence of living in a diverse world. Now, there are some successful cross-cultural health communication strategies that we can use. For one thing, we can learn keywords in another language. If we are a provider and we encounter a lot of Spanish-speaking individuals, then it would probably be good for us to learn a little bit of Spanish. Even if you're never going to be proficient at it, that's fine. Like, you should still try to increase your understanding, because you can never study a foreign language and not learn something. Every foreign word you learn teaches you something about that culture as well. We can also try to avoid slang whenever we're having cross-cultural exchanges. Recognize that slang is not universal, right? These are expressions, these are idioms that we use, and they do not translate well, and that can be a barrier as well. So try to be using straightforward and precise language can be more helpful. Use full sentences if you are interacting with an interpreter, because again, we are recognizing they are individuals too, and they are going to be interpreting things on the fly. If you only give them half a sentence at a time, they may misunderstand the meaning and translate it wrong. Always clarify when you sense confusion. This goes for all of us. I think if you are speaking across cultures or you're just talking to a friend, right? If people seem confused, then it's probably worth clarifying what we mean. Particularly, this becomes more important when we're dealing with a cross-cultural, cross-language exchange. Age. Of course, this is important. It's important in a lot of different ways. The age of the patient matters for their risk factors, their health literacy, and their ability to communicate effectively. For example, children have limited understanding of medical terminology, they have limited language use, and they have limited cognitive abilities in terms of their ability to grasp abstract concepts, of which there are many in medicine, right? But they do still have similar concerns to adults, and making them feel empowered or like they have some control over the situation can reduce their anxiety and improve their outcomes. Now, children go through different stages of understanding. One would be pre-logical. Here's a pre-logical example. My son, as of the recording of this video, yesterday I had to keep both of my children home because they are both sick right now. And my son has had some problems with croup in the past. Croup has to do with a hollow barking cough associated with constricted airways. It's a little bit like an illness-caused asthma attack, and it's more common in young children. My son has had problems with this before. He had problems with this the other night. We were up in the middle of the night trying to explain to him why we should try to use this emergency inhaler or we were going to have to go to the hospital. But he's 3.5 and he doesn't have very clear understanding of that. This is a screenshot from a video that my wife showed him to try to help him understand what was happening to him. And I don't think that this was an age-appropriate video. He's now obsessed with it for some reason, wants to keep watching it. But this screenshot is him, what he fixated on. He kept asking me, Daddy, why are the ropes tightening my chest? Right? This is in the pre-logical stage of childhood cognition. Obviously, this is still a little fresh to me. I'm still exhausted from being up in the middle of the night trying to explain to him that no, there aren't ropes constricting your chest. This is trying to illustrate how it feels. He cannot understand that. And so showing him this video probably didn't help. It might have just increased his anxiety and his concern. The concrete logical conceptualization, this is the ages, usually by age 7, kids are able to distinguish between external influences, such as thinking that there are ropes constricting you or monsters attacking you. Once you get to be about age 7, you're able to more clearly understand that, well, my difficulty breathing is happening inside my body. It's not an outside factor influencing it. And then once we get to about the age of 11, our formal logical stage starts kicking in, and children are able to have fairly sophisticated understandings of health at that point. You're still going to need to explain those vocab words to them, but that's going to be taking them more in the right direction. Now, parents, this is another important factor, right? Parents can be overbearing, but they are the caregivers in most situations. I am with my children very frequently, and when we're alone in the middle of the night and we are having health emergencies, I'm the one who has to make the decision whether or not to take them to the hospital. Well, my spouse and I, right? We are the parents. That's a hard decision to make. So providers can be frustrated with parents, but they are the first and last line of defense against health issues for their children. So there are communication strategies that can make this better, but outcomes are best when parents are involved and understand the issues. They are the ones who are going to give those children medicine at home. Compliance is kind of on them, as is comforting those children at most times. So we have to be a little compassionate because speaking as a parent, there's literally nothing more important in my life than my children, hands down, no question. So obviously I'm going to be a little touchy about their health. Perhaps one of the most obvious considerations of age when it comes to health communication is that of the elderly or older adults. And for good reason. This demographic, the stratification of age changes our risk factors, it changes some of our cultural factors in terms of how we were brought up, in terms of respecting authority, and it affects a lot of other things in terms of ability to communicate, ability to get around. All sorts of things are factoring in with as we age. This is a natural progression of life. We all get older. So why do we still have a lot of perhaps backwards thinking when it comes to age. There's a lot of stereotypes, there's a lot of misconceptions, and this is a natural life cycle, right? But the fact of the matter is the population is aging. The United States domestic population, we are getting older all the time. I've shown you examples in the past. The Japanese population, for the first time, 15% of that population is over the age of 70, I believe is what it was. And this is a common issue for all developed countries. It's just a typical thing. As countries get more well off and more developed, the average life, the age increases. And so we need to recognize these issues and try to deal with them. Ageism is a serious barrier here. As I mentioned before, there are lots of misconceptions about people's age and how they are able to function. Issues with this would be speaking slowly and loudly and assuming that an old person can't understand or hear you for some reason. Well, that can be a problem. There is a role of accommodation here in the theoretical sense. The textbook mentions accommodation, communication theory, which has to do with how much we are trying to act like are interacting, right? So if we are interacting with an old person and we try to talk like them, or what we perceive them to speak as, slower or louder or whatever it means, they may even mimic that back at us and kind of reinforces this unhealthy relationship. But in reality, like, these people are, even if someone has hearing difficulties, they may be very, very intelligent. Probably are much of the time, right? My dad has got hearing aids and he can't hear for anything, but he's one of the highest educated people I know. And when you treat people other than that, then with respect and individuality, they can start to learn helplessness as well, right? They can feel like they don't have much agency. This can be a problem in nursing homes as well. The idea of learned helplessness. If you treat people like they're less likely to recover from an illness, well, they're going to be less likely to recover from an illness. They're going to believe it themselves. And this is a problem in nursing homes. I've got a friend who works in nursing homes and reports this kind of things. Like, the nurses are kind of flippant about some of the health problems that could be prevented because the people are old. That is a problem, and that's going to obviously aggravate health outcomes. Technology is another wild card here. This is a double-edged sword in the sense that we have more information, but technology changes quickly, and if you are later in life, it may be more difficult for you to learn a new skill. Not always, though, and we shouldn't assume that. In fact, leveraging technology can really help some of these problems associated with aging and interacting with older adults. So if you have older adults in your life, and they don't understand how to use their phone or some of the resources that you do, hey, maybe take the time to show them how, because that can really help their quality of life. And it can help them fight that sense of learned helplessness, and it can help them take more control over their health care. Disability. I think this can boil down to the idea that most people with disabilities would still like to be treated like people, and they would like to be able to use space in a similar way to other people. So that's why we have accessibility, why we have things like wheelchair accessible ramps and things like that. It's to try and make the space accessible, right? So people with disabilities are still people. The disability doesn't usually profoundly change their human nature, right? So we want to try to be accommodating, but not like weirdly over-accommodating to make people feel worse about themselves. Sometimes it takes a few extra steps or a different approach, but at the end of the day, the goal is pretty much the same, is to live our lives as close to normally as we can and enjoy all the things that everyone else can enjoy. So it's important to try to be sensitive to the unique needs of people with disabilities, but not patronizing. Everyone possesses disabilities and abilities to different extents. And that's something that the textbook is good about reminding us of. So when it comes to accessibility, the governing philosophy should be, we are all disabled in our own ways, right? We all have limitations, and we just kind of want to live our lives. So we could spend a lot of time going over the specific strategies the textbook brings. They're unique to the different disabilities, but I think they all fall into this kind of category. Trying to treat people like people and not doing a horrible disservice to them by treating them as if they need an abundance of help when they don't, or even worse, regarding them with some sort of non-person status. That happens too, and would be a very bad sign of discrimination against individuals with disabilities. Finally, let's talk about gender identity and sexual orientation in health communication. I saved this one last because it works as kind of a segue into reminding ourselves of the importance of individualized care. These are not the same thing, but they face similar challenges. Now, same-sex relationships and health behaviors, for example here, entail some unique health risks. And if the doctor doesn't know about that same-sex relationship, they will not be able to help you adequately address those risks. These relationships face similar risks to heterosexual relationships, but again, individualized care is the name of the game. Now, the old adage goes, there's two people you should never lie to, your doctor and your lawyer. Not to suggest that this is about lying, but if they don't know about a certain behavior, then that could be a challenge for them. And so there is this idea of comfort and disclosure, and the textbook mentions that sometimes people in same-sex relationships might feel like they're committing a lie by omission because the assumption may be that they're in heterosexual relationships. So there is an issue in terms of that comfort and disclosure. That can dehumanize people in terms of making them feel like they are abnormal or that they are marginalized or they could literally be discriminated against. But also the doctors might miss critical health information that are unique to the risks faced by those unique groups. An additional challenge here is one for spouses and loved ones not being able to participate in healthcare. So if people are uncomfortable disclosing their relationship status, then that could complicate the ability of a loved one to interact in terms of those critical life choices and healthcare decisions. Thankfully, this has been somewhat ameliorated by the Supreme Court ruling of legalizing same-sex marriages, but it's still a challenge culturally when people do not feel comfortable disclosing their status in that way. Now, likewise, from the provider perspective here, they may not actually be all that equipped to communicate about these unique challenges of these demographic groups. This is an ongoing development. It seems like our society is in the process of renegotiating how we feel about gender identity and sexual orientation to a certain extent. And some of these issues are not resolved, at least not to the satisfaction of a wide range of demographics. We could take this back to age. If you are in a same-sex relationship and have been for many, many years, you may have come up in a cultural understanding that is different than the current cultural context, and the same applies to doctors as well. We can and ought to work on this, however. We can improve our understanding of these things, and it begins with education and improving our own knowledge and self-awareness. So, diversity, representation, and empathy. I think it's best to end where we began here, recognizing that everyone has their unique identity groups that they are part of, their unique challenges, and while we can detect individual trends associated with categorical differences, it's always safer to operate on an individual level. Treat individuals like individuals, treat them as the unique people that they are, and that means trying to take their perspective, learn about their existence, and do what we can to improve their health outcomes. Hope this was useful and interesting for you. I'll see you next time.